Hello, my name is Dr. Ian Hargraves. I'm a shared decision-making researcher at the Mayo Clinic in Rochester. As part of my work, I work on the development of tools to support shared decision-making. And in the current paper, Developing a Conversation Aid to Support Shared Decision-Making, Reflections on Designing Anticoagulation Choice, we discussed the process that we went through in developing a conversation aid to help patients and clinicians discuss what to do about the increased risk of stroke associated with atrial fibrillation. In the paper, we discussed the many challenges that we faced and judgments we made with respect to what evidence to draw on in the aid and how to present this information so that it practically helps everyday patients and clinicians make good treatment decisions together. Atrial fibrillation is the most common cardiac arrhythmia. It affects approximately 5 million Americans and is associated with a 5-fold increase in a person's risk of having a stroke. It is commonly treated with an anticoagulant to prevent blood clots from forming that could cause a stroke. At the Mayo Clinic National Shared Decision-Making Resource Center, we think of shared decision-making in a pretty straightforward way. We think of shared decision-making as simply a conversation in which patients and clinicians work through what to do in response to a problem. In the case of atrial fibrillation, this means understanding the risks that the patient faces, whether or not to pursue anticoagulation therapy to reduce it, and how best to incorporate these medicines in the patient's life. The Anticoagulation Choice Decision Aid is designed to help patients and clinicians talk about whether or not to anticoagulate by calculating the patient's current risk of stroke using a CHADS2-VAS calculator and presenting that risk visually in an icon array representing 100 people like the patient, along with how that risk may be reduced in absolute terms through anticoagulation. If they're interested in anticoagulation therapy, they can then go on to discuss how best to introduce anticoagulation in the patient's life, through warfarin or one of the newer direct anticoagulants. As the efficacy of these treatments is similar, discussion is mostly focused on practical issues of implementing treatment, issues such as time required for monitoring, cost, activities that might put the patient at risk for bleeding, and diet and medication interactions. After working through these issues, patients and clinicians are at a point where they can make a decision. As part of the tool, it also generates text that can be used to document the discussion within the EHR. We developed the tool on two fronts. We had an evidence team that found, evaluated, and combined the relevant evidence so that it would best serve the conversations that patients and clinicians are having. And secondly, we used a human-centered design approach in which we talked with the end users of the tool, patients and clinicians, about their experience of living with, managing, and making decisions about treatment for atrial fibrillation. We also spent time setting in on or video recording real patient-clinicians encounters in which treatment decisions were being made. We did this so we could understand what was happening in the real world, what the challenges patients and clinicians face in decision-making, and how we might help. Once we had a sense of what was happening in various clinical contexts, the emergency department, cardiology, primary care, thrombophilia clinic, etc., we began to develop prototype conversation aids. We asked patients and clinicians to try these out in real decision-making conversations, and through observing the prototypes in action, we iterated and refined the aid until we had a final aid that helped people make decisions together. A surprisingly hard part of the process was finding and curating the evidence around atrial fibrillation and its treatments that practically helped patients make decisions with their clinicians. For instance, the issue of bleeding risk associated with anticoagulation therapy. A common medical approach is to set the risk of stroke against risk of bleeding, but we found that this comparison was challenging for patients as the experience of stroke and bleeding are not directly comparable. Also, many clinicians felt that the available evidence on bleed risk did not reflect contemporary anticoagulation practices. The finished aid is currently being evaluated through a randomized controlled trial in 1,000 patients in 5 geographically diverse healthcare systems. For those who are interested in trying the aid, it's available at Anticoagulation decisionaid.mayoclinic.org. We hope that you find the article in the Mayo Clinic Proceedings interesting. It goes into greater depth discussing the issues involved in finding and employing evidence within the decision aid, how the decision aid was developed, and future implications for the development of other conversation aids.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.